Welcome to our State of the Technology presentation on automated chest compression and field ECMO. Here to share his insights and expertise on this area of technology is Dr. David Wampler. Dr. Wampler is a PhD and paramedic with an academic appointment as an associate professor of emergency health sciences with the University of Texas Health Science Center in San Antonio. He has over 30 years of EMS experience and currently serves as the Director of Clinical Research for the Office of the EMS Medical Director with the San Antonio Fire Department. Dr. Wampler studies the science of resuscitation, including the medical and traumatic causes of extremis, and that work makes up some of the 90-plus peer-reviewed articles and abstracts that he's published. Twice, his work has earned the Research of the Year Award at EMS World Expo. Welcome to the conference, Dr. Wampler.
Thank you, Mick. I really appreciate the invite. You sort of forced me to do research on this area, which is sort of my thing anyways. I got to talk to some really cool people that know a lot more about automated chest compression devices, and so this should be a lot of fun.
Well, knowing that you do resuscitation research, I'm sure it wasn't too far afield for you, and so that's one of the reasons why I wanted to get you to do this particular presentation. So with that, help us all understand how to make well-informed decisions when considering options for purchase of this kind of technology. What sort of insights can you share about what buyers should be looking for with these devices?
Sure. So really there's two types of chest compression devices. There's the load constricting band type of device, and then there's the piston driven type of device. Both of them are fairly similar in concept. That is, they both squish the chest, and the chest gets squished, blood leaves the chest and goes to other places of the body. And then they relax, allowing natural recoil of the chest, which allows blood to return to the heart to get ready for the next cycle. They work in a similar physiologic concept, but they have two different mechanisms to make that happen. The load constricting band sort of squishes the whole chest. The piston devices usually have something that contacts the chest right in the center, and then it pushes down the AHA recommended 2.5 inches, whatever that is. So strengths of both of these types of devices is the cognitive and the physical offloading of the process of having to maintain high quality chest compressions. That's what they really do, is perform high quality chest compressions so that your rescuers can go off and do the other components of resuscitation that need to be done here. The limitations of them, well, the distributing band, they have a lot of disposables that you're going to have to replace after every cardiac arrest. But it's pretty efficient in what it does. The piston devices, there's a couple of manufacturers, there's I think 3 or 4 manufacturers out there right now. Some of them have 2 arms, some of them have a single arm that comes around, secures the device to the chest. One manufacturer has a suction cup that actually attaches to the chest, and we'll talk more about that in a little bit. The other one had just sort of a blunt, semi-soft, rigid interface that attaches to the chest, and it does the compressions. Most of those are more durable. The piston cup is replaceable. The durable components to the other devices they're just durable. So as long as your patient that you're trying to perform resuscitation has good chest wall integrity, all the devices sort of perform similarly. Once we lose chest wall integrity, that's really the main limitation to all of these devices, is that once you lose that natural recoil of the chest, now there's nothing to bring it back. Now, the piston cup device, actually, because it actively returns to neutral, that actually does help some in bringing the chest back into a sort of more expanded thing, ready for the next compression. But that's really the only main advantage to that one particular device.
So with the loss of the chest wall integrity that you're referring to, we're talking about broken ribs, I'm assuming. And
broken ribs, separated sternum, those types of things. Yep.
Right. Which you'll commonly see working the code, particularly on an elderly person. You'll get that cracking of the calcification of their cartilage and those sorts of
Mhm.
things. Is that where you would anticipate loss of that recoil, or is it with something more severe than just that cracking of the calcification of the cartilages?
So it's age dependent, right? Very young patients have really pliable and more plastic chests, and they can tolerate chest compressions well. Patients with some sort of bone disease or cartilage disease, or just the natural aging process, that chest gets more rigid, and you'll break ribs, you'll separate the sternum, you'll get cartilaginous damage, and all of those things reduce the natural recoil that comes back. Um, Now we're going to talk about upcoming stuff in the future, but um, the neat thing about the one device that has the suction cup is once it does the compression, it does potentially in the future have the capability of doing active decompression, so actively pulling the chest back up. And so that's one significant advantage of that one particular device, is some future potential. It's not FDA cleared to do that right now, but that is something that is being investigated currently.
Right. And this whole issue of the chest wall integrity would be just as valid for manual compressions as well.
Absolutely. In fact, I think we probably break more ribs than these devices do, because the devices are very consistent in the chest compressions they deliver. We are much more variable, right? As we get tired, either we lean on the chest more, or maybe we put a little bit more weight down on theirs. The devices are much more consistent in their delivery of chest compressions.
So that kind of brings up the next question. So buying the right technology is only part of this journey to trying to deliver better care during resuscitation. It also has to be properly implemented. So are there any best practices associated with implementing automated chest compression technology that buyers should be considering in their purchase decision?
Yeah, whatever device you buy, um, the most important thing is training. Train with it. Train, train, train. If you think you've trained enough, you're halfway there. Keep training. Um, the other important thing to remember here is these devices are not clinical difference makers. These are resource difference makers. There have been lots of studies that have come out, and nobody yet, not a single study, has really shown a significant clinical advantage to using chest compression devices. I will talk about one in just a minute that there might actually be some benefit to, but to date, nobody has been able to show clinical benefits. So really the value of these devices is as I mentioned before, the cognitive and really the physical offloading of the demand of high quality chest compressions. Once your team leader knows that chest compressions are taken care of, then they can go off and do all of the other life-saving things that need to be done with that particular resuscitation. So they can tailor the resuscitation to that particular patient's problem. Um, Chest compressions, cardiac arrest, chest compressions are what save lives, right? Defibrillation, if they're in VF, that's what saved lives. The other part of resuscitation is all the other pieces that cause the resuscitation. You got to fix those in order to fix the resuscitation.
So there's a lot of buzz around doing so-called pit crew CPR. How does looking at that as a best practice, if you will, how does automated chest compression fit into the use of pit crew CPR?
So pit crew, choreographed, whatever name you want to put on it, really. So the reason why chest compression devices have not shown a clinical benefit is because of what they do. They do high quality compressions. That's what first responders also do. We train to do high quality compressions. If our first responders are doing high quality compressions, the exact same potential that this device is, there's not a clinical benefit. So really, it is a situational and a cognitive and a physical change. So that goes back to the training. Train. Choreograph the placement of the device with your training, right? You can't just stop compressions while you apply the device. It doesn't work well that way. You lose time, you lose brain, you lose blood flow, that blood flow inertia. It takes a long time to get that inertia back. So make these the incremental steps of getting the device deployed while you're still maintaining high quality chest compressions. That's the main piece there.
Okay. Now, sometimes the purchase of technology and its implementation has some pitfalls. What are some common mistakes or pitfalls that buyers should be aware of or take steps to prevent or avoid with automated chest compression technology? You talked about, some, but perhaps expand on that a little bit.
So again, don't think that this is going to be a clinical change maker. This is a device that is going to help you manage the scene well. Don't think that you're going to see significant increases in survivability, because you're just not going to. Now, where some real value here is, and where you have to be careful, is your first responders do really good chest compressions while they're on the floor or on the scene, right? It's transitioning from the scene to wherever they're going to go, whether that be from the house down the stairs to the unit, or from driving from the scene to the hospital. All of those are times where we can't do good manual compressions. We need some good quality chest compressions. And I think that's best delivered by a mechanical device. The caveat to that is that's going to make us give us a little bit of false sense of confidence that we are getting good circulation. And really, the important thing is to stay on the scene, get a pulse back on the scene. Unless you're going to be transporting a patient directly to the cath lab, you need to stay on the scene and make sure that you've got all of your things taken care of there. That's where the real value is. The chest compression devices, if we're in transit, they're probably a better way to deliver chest compressions. So that's the piece there, is that's where you're going to see your clinical benefit. David's opinion.
Yeah, no, and there's been a lot of literature out showing, the loss of compression quality when you start moving the patient, making the argument for staying on the scene before you get ROSC. But you could have those cases with refractory ventricular fibrillation and the so-called heart too good to die, and those might be the ones where they want to take them directly to the cath lab because maybe they got that widowmaker STEMI going on, and until they clear that clot, they're not going to stay out of VF. So no, that makes a lot of sense. I guess the other thing that occurs to me, Dave, is the whole notion of trying to make sure that your crews have kind of optimized their manual CPR technique before you introduce the automated. It's not a way of getting around doing good manual CPR, because obviously there's going to be some time before you put on the device that you need to be doing good quality chest compressions. And as you mentioned, you want to minimize those off the chest times to quickly get it in with minimum interruptions, because it's all about that compression fraction. And that's the thing I've always thought about with these devices, is really optimizing that compression fraction. Have you observed any changes in people's typical compression fractions when they've introduced automated CPR?
Yeah, that's a really interesting question, Mick, because there's a famous paper came out. It's been probably 10 years now. Dr. Brent Myers and Jose Cabanas out of Wake County, they published a really, really nice paper where they sequentially introduced different treatments and looked at the impact of those treatments. And the really interesting thing, the point about that is, and it goes to your point, is every time they introduced some new element to their resuscitation, they retrained everybody in how to do CPR. They trained everybody in this new widget, this new procedure, this new thing. And every time they introduced a new one, they got a little bit better. So my thought is that this was not really a staged deployment of new resuscitation techniques. This is reinforcing the training that you do at every step. So if you train a lot, you're going to get better. But you got to fight like you train, and you train like you fight. So train in real scenarios, use the tools that you have there. So if you buy a device, use that device in your training. Make sure that everything is coordinated And again, if you think you've trained enough, you're halfway there. You need to train some more.
Sure. So research and innovations, also, have a big influence on implementation of this stuff, as you've mentioned several times. And sometimes the next big thing is just around the corner. Sometimes it's further out on the horizon. And something, might be out on the horizon a ways. And that might be something to give you pause in considering the timing of a major technology investment because of that new thing that might be coming onto the market soon. What's going on in the realm of research or innovation related to automated chest compression that buyers might want to keep an eye on?
So the resuscitation bundle of care, really sort of being put forth by Take Heart America, which includes a lot of elements. It includes active chest compression, decompression. It includes impedance threshold device, and actually, once you restore good perfusion, whether that's artificial or natural, elevating the head to get all of the right physics of blood flow to the head. So this concept of heads-up CPR with impedance threshold and active chest compression, decompression, all sort of work together to improve blood flow to the brain, which is what we're really trying to resuscitate here, right? We've got to get the heart because that's what is going to sustain us, but you've got to get the brain functioning as well too. So the piston cup device has the capabilities within the technology to be able to do active decompression. It currently does not do that because of FDA rules. Very probably wisely, it's not doing it right now because we haven't produced the data to show that active decompression is actually going to save lives on a large scale. But that is, the technology is there, it's ready. We just need to be able to turn it on, and we'll be able to see some, I think, some significant differences with that.
Great. Well, there's one other thing I wanted you to touch on, if you would. Field ECMO is not a real big thing in EMS and emergency medicine yet, but it seems to be gaining some traction. So for those EMS systems considering field use of ECMO technologies, what insights or suggestions might you have about implementing field ECMO and choosing the equipment?
Okay, so field ECMO is eCPR as a way to assure circulation when the heart is not actually functioning and you're not doing chest compressions. So it's a way to bridge people from chest compressions to the cath lab, resolve their coronary disease, and restore functional circulation. It involves putting two very large catheters into two different vessels. This is a very labor-intensive process. It's a very high-skill process, and it takes a lot of very specialized technology. Dr. Yiannopoulos up in Minneapolis has shown some remarkable success. I mean, like greater than 50% survival, which is amazing in cardiac arrest situations. Now, these are very focused group of patients, so this is not all comers that's getting that high of a success rate. It's a very focused group, but they are doing some really, really, really good work. They're doing it right now in the lab, and they are starting to do it in the field some. They have tremendous resources to make that happen. They had a landmark grant given to an EMS agency to be able to do field ECMO. If you have a ton of resources, then I think field ECMO is absolutely the way to go. It's going to save lives. Takes a lot of resources. It takes a team, usually 3 people. It takes a really big ambulance with an awning on the back of it. It takes specialized equipment. You have to have a big ambulance and a small ECMO machine, and that small ECMO machine has to have a hand crank because stuff breaks. It's a resource-intensive thing. It's not ready for prime time yet. If you're looking at it, you mentioned earlier, pump the brakes a little bit. I think pump the brakes is the right thing to do here. Step 1, find a hospital that will do ECMO in the hospital. 1 shock, 2 shock, go. If they're in a refractory VFib, take a patient that has ECMO there. If you can get them there within 30 minutes, the Minneapolis group has shown phenomenal success there. That's step one. As you get really good at that component, now you can start talking about bringing that field ECMO out there. Again, you have 2 physicians on that truck. You have to have a perfusionist on that truck. You have to have a big truck, small ECMO. It's going to be a lot of resources and some time before that's ready to go.
Well, great. All that was really, really helpful, Dr. Wampler. Thanks for being here to help us all better understand some of the things we should be taking into consideration when contemplating the purchase of automated chest compression technologies. We're going to return to the live feed for your questions and comments in just a moment, so please start submitting your feedback and asking questions. We'd love to hear from you. If you'd like to ask your question by appearing on screen with us using your webcam, please click the raise hand icon in the upper right side of the browser window. We'll then be able to select you from the queue and bring you into the video feed. You can also just type in your questions or comments using the questions tab on the upper right side of your browser window as well. So here we go, back to the live session.